Hey guys, this is Charity Stanley, and you should be seeing my screen. I just wanted to let you know that I have updated the class schedule to reflect next week's changes, where we'll be having the HESI on Tuesday evening and then the math test on Wednesday, followed by concepts for care for patients at the end of life. We also will have a burn section that needs to be covered. So I will have that posted by Sunday of this weekend. And then the next week, we have our first test. So reminder that HESI is due on Monday, 2/5 at 11:59. And these are all equally weighted this term. So just be prepared for those to be completed. And then we will get on with our lecture for today. So today we are covering organ and tissue donation. Organ and tissue donation is something that is life-saving and is vital for those people who need a new organ, whether that be skin is actually an organ. So often in burns, you'll see skin transplantation. Also in organ donation, you can donate your heart, lung, part of your liver, do the entire liver. And cadaveric, that means somebody who's already died. It's a cadaver donation. Um, and you can also donate different types of tissues as well. So you can donate skin, as we talked about. You also can donate different types of cartilage, like a cadaveric ACL transplant. So, to donate, one of the big things is that you are 18 years old. Now, some exceptions can be put in place for that. If the parents actually say it's okay, then organ donation can happen with a 1 week old baby. The recipient has to be about the same physical body size as the donor. And we've talked about MHC complexes. Remember those signs that each individual cell holds up that says, "This is me, this is me." You have to match 5 out of 8 MHC. That's the major histocompatibility complexes. So you must share 5 out of 8 of the transplantation MHC antigens. So once we do a transplant, we often have to manipulate the immune system to help prevent rejection of that transplant. When we say that a transplant is being rejected, what we are actually meaning is that the body is trying to attack that transplant because it recognizes that those skin cells, those liver cells are not yours, not the patient's. And so as a result of that, the body tries to kill that tissue. And so with that, we have several different medications that we can use to help prevent any kind of tissue rejection, organ rejection. And so with this, first is cyclosporin. This is going to be the classic one that you hear um, when you're talking about preventing rejection. Cyclosporin is a very strong medicine, and what it does is it stops the immune system from working as well. Now, by stopping the immune system from working as well, that sounds like great for the transplant itself. But what other consequences could that have? It has widespread systemic consequences because when you stop the immune system from working as well, you are also allowing the different viruses and bacterial infections to run amok throughout the body. So, cyclosporin is often a medicine that's used. We use steroids as well in cases of acute rejection where we're trying to temporarily turn off. These are used in conjunction with cyclosporin. Tacrolimus is a newer transplant rejection medication. It works the exact same way as cyclosporin, and it is an immunosuppressive drug. So, monoclonal antibodies, these are going to be medications that are ending in the suffix of DAB, DAB. So, these monoclonal antibodies can help prevent rejection from happening as well. So, when you're on these medications that are manipulating your immune system, these medicines are very dangerous if the patient is given too much or if the patient's given too little. So, it's very easy to become toxic on these medications because they're very powerful medications. So, we have to monitor for toxicity on all of these different meds, and we need to make sure that we are giving them the correct medicine, the correct amount of medicine. And the way we do that is through blood testing to see where the drug level is in the patient's body. So, as we said, we also have to monitor for infections. So, you may also see people who are receiving organ transplants, you may see them on neutropenic precautions as well, because they are at such high risk for infection. So we have several types of rejection, sorry. The first type of rejection happens within the OR. So as soon as we get the new organ put into the body and establish blood flow to it, this type of rejection happens in minutes. So the patient's immune system immediately attacks the organ. So, one way that the body will try and attack the organ is through creation of clots. And in creating clots everywhere, it stops the blood supply to that organ. It's the body's way of killing that organ. There is really nothing that we can do to treat this. So, we literally remove the organ immediately. Now, if this is a major organ transplant, like let's say a heart, then it is unlikely that the patient is going to live very long once we put that old organ back in, okay? Because there's a lot to these procedures. But hyperacute rejection happens in minutes. And the way we know that's happening is through severe pain, through clotting, through inflammation, and their temperature goes up immediately. And that happens within minutes. Acute rejection. Acute rejection happens within about 1 to 3 weeks. So, with acute rejection, we've made it through that emergent hyperacute phase, okay? We don't necessarily have to take out the organ. What we can do is start giving additional steroids to get them through this acute rejection phase. And so we are often increasing immunosuppressive meds, giving them more cyclosporin, giving them more glucocorticoids to maintain organ viability and to keep that organ alive. Chronic rejection. This is going to be what happens after a month, after a few months. Okay. So, chronic rejection, the way that we treat this is we will also increase the medications, but a certain point of chronic rejection is actually expected and normal within the case of any kind of tissue organ transplant. So, as long as the organ is still working, we keep it in the patient. If the chronic rejection starts attacking the organ's function, we may have to remove that organ and replace it with another transplant. So, through this chronic rejection, we may have to increase the medications for immunosuppression over short periods of time, but we also can wean them back off those higher drug doses. Graft versus host disease. Graft versus host disease results from stem cell transplantation. The way that we get stem cells is we actually stick a really long needle, probably about 6-8 inches, into a patient's hip, and we are actually pulling out the bone marrow. And so this is where we get the stem cells from. So when we're putting them in another patient, we literally do the opposite. We inject them into the bone marrow. So stem cell transplantation actually is more painful for the donor than for the recipient. The recipient is already so sick that they start to feel better after receiving the stem cells. So with graft versus host disease, the graft, the transplanted stem cells, are healthier and they will start to attack the host tissues. So this most commonly happens in areas like the eyes, the skin, the lungs, and the GI tract. What you will see is a rash on the palms of your hands and the soles of your feet. Okay, so it's very rare on non-hairy skin to develop rashes, but that's exactly what you'll see in graft versus host disease. So common symptoms, this is an example of a maculopapular rash on the hands. You're going to have severe abdominal pain as it's attacking the GI system, bloody diarrhea, and scarring of the bronchioles. So what we do to fix this is we increase immunosuppressive medications temporarily to turn down those stem cells' ability to attack the host tissues. So a kidney transplant. Kidney transplants work immediately as soon as they're hooked up, and they often produce very large amounts of urine on that first day because kidney transplants, the host has not been able to get rid of the toxins as efficiently with one kidney. And so as a result of that, that they do produce a large amount of urine immediately that first day. The urine may have tinges of pink coloration, and that's due to there's bleeding that has happened with putting in the kidney. And so this is considered perfectly normal for there to be pink tinged urine in a kidney transplant. So with a kidney transplant, if the patient is not producing a large amount of urine, they often are at risk for organ failure. And so by keeping an eye on the urine production, we're able to see exactly how the body is accepting the new organ. So after a kidney transplant, we've gotten really good at these over the years. Um, and so the most common cause of death after a kidney transplant is not kidney related. It's going to be due to some other cause of death post transplantation. So we have different types of ways that we can get organs. The most common that you're going to hear about is the deceased patient. So this is where the organ procurement organizations go out and actually talk to family members about their loved one and make the ask for the organ. Now, with this said, you as the nurse that is caring for this patient, attempting to save their life, you do not want to be the person who is asking for that organ, because what can happen is things get muddied within the family's mind that, oh, you just wanted my son's organs. You haven't really been trying to save his life. Whereas if we can draw clear boundaries between you are the person who's trying to save the son's life versus the organ procurement organization nurses who are asking for the donation, it makes it easier for families to be able to cope. So you also will see things in pop culture about selling organs. And going out on a bad Tinder date, being found in a bathtub packed in ice, bleeding, missing your kidney. Now, in the United States, that kind of thing does not happen. In other countries, unfortunately, that does sometimes happen. But in the United States, that is not an issue. Now, living donation. The donor is still alive, so I can do half of my liver. They can take out half my liver and put in somebody else, and that liver will regenerate. So what that means is where I've had half my liver cut off, a year later, I'll have a full liver. A year later, that half of the liver that was donated and put in someone else has since regenerated into a whole liver. Okay. So, kidney, I can live off of one kidney, and that's kidney donation. You can do living kidney donation. You can donate part of the GI tract and splice the GI tract back together. You can donate part of the pancreas, part of the lungs. You can donate stem cells. So the only organ that cannot be donated and transplanted is the brain. So common organ transplants are kidney, stem cells, and liver. These are the most common types of organs that we donate. Okay, thank you guys. I will have your burn lecture up in just a couple of days. Stay safe and warm.